Okay, just making sure that we are live for our weekly What's Up Doc series, and it usually will cut me off. So I'm going to go ahead and I clicked out of YouTube, but we are live on YouTube. We're actually live for our weekly What's Up Doc series with Dr. James Antezana, one of our limb savers, our Dr. Miracles over there in Charlotte, North Carolina. We have several folks that he's actually treated successfully that have joined the call today that will want to say hello, and also they might have a few questions for you. We have quite a few in our live studio audience, Dr. Antezana, so we're going to try and roll through these. I know you're in the middle of cases, but it sounds like you just got through a really exciting case. You just walked right out of the cath lab and turned on your camera.
Absolutely. Thank you, Kim, for the opportunity to be able to share some of my experiences and my expertise in the field of limb salvage. I just got done with a 54-year-old veteran who had sustained a lesion to his left lower extremity about 20 years ago after a massive explosion out in Iraq. And he was intervened by the interventional radiologist who ended up stenting his limb proximally in his thigh, and then they put a bunch of stents inside his tibial vessels. And he occluded, and he had chronic lower extremity pain, which he endured for many, many years. And then he heard about us, and we examined him, saw that he, at that point, was having rest pain, normal flow on the right side. I took him to the OBL, or office-based cath lab, and then found that the proximal superficial femoral artery stent was completely thrombosed and occluded. And then his distal stents that were placed in the TPT trunk and perineal artery that jailed out his anterior tibial and his posterior tibial was completely gone. So fortunately, he's young, and 20 years ago when he was younger, he developed nice collateral beds. But since his proximal SFA stent had occluded, he started to have symptoms of rest pain. So now that's opened up. His symptoms are going to get better, and we're just going to put him on a walking regimen. And if that doesn't work, well, he'll need a bypass to his anterior tibial, which is the only decent vessel that I saw, that reconstitutes through all these beautiful collaterals. It's so important for patients to understand that it's not the end of the world when they're completely blocked up. You still have the option of collateral blood flow that can be recruited with time and exercise, and these vessels get big enough that the patients can, continue to walk to a certain degree and preserve their limbs.
And so you're talking, for those that are watching that aren't familiar with some of the lingo, the superficial femoral artery, that is in the thigh. And you were saying that the stent that was placed in there was completely blocked up. So I would imagine you would have gone in there, and what's indicated for an in-stent, what we call restenosis or blockage, where you get it mucked up with all kinds of gunk that build up right there in the stent, is you probably took a laser and then a drug.
I did, absolutely. A laser atherectomy is the indication for a in-stent restenosis or a completely occluded stent. It works by photo ablation, and the laser evaporates the plaque. This laser, it's an excimer laser from Spectranetics, which Philips is the company that sponsors it. This laser is designed to work on soft and moderate mixed plaque morphology, not very calcified lesions, but lesions in between that are partially calcified and have a lot of fibrotic material in them. This stent was a mixture of thrombus with neointimal hyperplasia, which is new tissue growth on the inside that happened through many years. And then he just completely blocked up. So today we opened him up, and he looks great. He's filling his distal collaterals. Everything is beautiful. I still have an option of going through the foot into one of the tibial vessels and kind of rebuilding that anterior tibial as another means of doing surgery to help him relieve his calf pain and his rest pain in his foot. But I think with the proximal stent that we opened up, he's going to have plenty of blood flow and he won't have any rest pain. He might have some short distance claudication, but we can work with that, slowly and see how he does before we do any more interventions.
And I think that this is really an important point for people. I really like your less is more approach. And there are some doctors that would go in there and they would do everything all at once. And with peripheral artery disease, it's a progressive disease. And you're limited in the number of times that you can go in there and go in there and go in there and go in there with a revolving door of treatment. There's only so much every single time you do go into these vessels, there is trauma to the vessel. And so you do have to be very, very careful and be very strategic in your approach to opening up these vessels, especially below the knee. Now, you bring up something interesting. Were you surprised to see stents placed? I know that there are some doctors that will place
Yeah,
like
I was
a
20
cardiac
years
stent for them.
ago. 20 years ago, we didn't have the experience of putting stents into the TPT trunk and the perineal vessels, and the size of the stents were probably not adequate. I was surprised to see that, but he was done in a military facility, and they were doing everything to reconstitute blood flow, but. I think that, not knowing the case fully, I really can't weigh in my opinion completely. But sadly, all the stents that they placed in 20 years ago are completely gone. And this young 54-year-old man
Wow.
cannot get around because he's got no decent blood flow down to his foot. And his toes are, discolored. He's got pending rubor. You can see that the toes are severely red. When you lift up the leg becomes completely blanched because it's not getting enough arterial blood flow.
And do you think that something, some of the new innovation that's happening below the knee in terms of technology, such as Abbott's new Esprit biodegradable stent, might be something that can make a difference for him down the road? Or because you were mentioning that one of the stents that was placed, you said jailed. So what he means by jailed is it's blocking off, so it opened up one artery and it's blocking off another, correct?
Yeah, I think when you're working with small vessels like that and you've jailed out some of the important tibials, you're left with not many options. And I think for this man being 54 years old, probably the best option, if this does not resolve it by fixing the proximal SFA stent, he's going to need a bypass surgery, and it's going to last him for the rest of his life. If I go in there through the foot and try to salvage that anterior tibial, for example, and reconstruct that, I'm going to end up with the same issue down the road. It's going to clog up. So I'm gonna allow this first stage of my procedure to carry itself with recovery, and see how he does, and see if it's going to stay open, which I believe it's going to stay open. And if it stays open and his symptoms are relieved, in that case, then we can continue to observe him for a bit until he really needs to have that bypass procedure. But going in there and heroically trying to fix a tibial vessel that's already been adulterated, and it's not in a state where you can reconstruct it appropriately without having another stent within a stent. It's just a mess. So
Yeah.
in this case, we're just going to observe and see how he does just with the proximal SFA stent reopening.
And for someone, there was the best CLI study that came out, this global study that came out that was saying that bypass is appropriate for many of these patients that are in the advanced stage of peripheral artery disease known as critical limb ischemia. The one caution that I always have with patients is that make sure you do have a doctor, if they're going to perform a bypass, that they're a doctor who truly understands the below the knee arteries and are going to be there to monitor the disease progression down there, because the last thing you want is to go through this major procedure for a bypass, have it reconnect and reroute blood flow around your knee, around some of the blockages above the upper calf and into a diseased vessel, and then have the vessels below not be able to support all that extra flow, and it just blocks right back up. But having someone like Dr. Antezana, who is a vascular surgeon who does both endovascular and general vascular surgery, and the most advanced tools and techniques he uses in the process of doing that, this is something that he definitely is aware of, and he is able to monitor and actually nip things in the bud and even go in a minimally invasive way, as you were saying, right? Come up through the foot, because if you actually reroute blood flow into the anterior tibial and it starts to block up, you can go in with a quick wire and balloon and just kiss it, and he'll be good to go. And as you said, it could last him a lifetime.
Yeah, that's correct. It's very important. The practice of medicine in the field of vascular surgery is a field where skill set meets knowledge and experience. And a good physician, a good interventionalist, has to have those three things. Has to have the experience, has to have the skill set and the knowledge. So his procedures are a complete success. And being cognizant of tissue healing and respecting tissue is very, very important when you're dealing with a bypass. The bypass is they should go perfect. The planning has to be, very meticulous. So when you do the bypass surgery, you're, looking at a high percentage of success, because if you fail and you go back in because your graft went down, the likelihood of that thing going down again is pretty high.
Yeah. So we do have quite a few questions. I could talk about that case all day, but we do have quite a few questions I do want to get to. One that was really a hot topic this week. We had a patient who had an ABI test, the ankle brachial index test, where they put the blood pressure cuffs on your legs and your arms in order to measure the differential and determine whether or not you have peripheral artery disease or the stage of peripheral artery disease. And she had a 0.7 6 months ago. Went in just the other day and she had a 0.5. But what was also interesting about the situation was, for the first time, her blood pressure in her arms was higher than normal. And the doctor told her that the reason it seemed as though her legs weren't doing as well is because her blood pressure in her arms was artificially higher. I wondered if you had experienced anything like that, or if you could discuss, whether or not high blood pressure might have an impact on your ABI results.
Yeah, absolutely. I mean, if your blood pressure is extremely high compared to the previous reading, it's going to throw off your TBI. I think the most important thing, though, when you're dealing with patients, is not treating the numbers. It's treating the patient, treating the symptoms, and your clinical exam findings are so crucial. All these, ancillary tests like the arterial duplexes and the ABIs and TBIs are only to confirm our suspicion. And so, she should be reassured if she doesn't have any symptoms that this number, it's just been thrown off because of the blood pressure elevation. Because if her blood pressure was lower, possibly, the numbers would be better. Although if the blood pressure was lower, the pressures in the toes would also perhaps be lower, but not necessarily, because sometimes in diabetic patients, you've got non-compliance of vessels, except for those little tiny vessels in the toes. So it varies. It's variable, and I think it's very important to match your physical findings to your ancillary test findings.
Is that why you typically, when my patients come to you, for the most part, you do a leg artery ultrasound? That's usually your go-to.
Yes, absolutely. So if I have a clinical suspicion that the patient has symptoms of claudication or rest pain or CLI, then I would take that patient to the cath lab and do an angio. If the patient doesn't have rest pain and it's only a claudicant, then, and we've maximized conservative medical management, such as exercise, smoking cessation, medications that help with claudication, like Platol, silostazole, medications that help increase the arterial blood flow into these crevices where the arteries are very narrowed. These things help. And if they don't help, then you take the patient to the OBL or the cath lab to do an angiogram. You have to exhaust all means of conservative management before you decide to take this patient to the cath lab, not unless the patient has critical limb-threatening ischemia, where you have to do something about it. Either it's rest pain or they have tissue loss, and then you need to act as quickly as you can. You can't maximize anything there. You just have to go and take the patient to the OBL or to the cath lab.
We have a question coming in from Denise. Are you okay on answering a few more questions?
Sure, of course.
Fantastic. Denise, go ahead, unmute, and ask Dr. James Antezana your question.
All right. So I feel like I've been kind of kicked in the stomach today. I just was told a couple of weeks ago that I have PAD. And today I went to a neurologist over some memory issues. And I was telling him about, that they told me I had PAD and I have an appointment to see a vascular surgeon in September. And he goes, well, I'm glad you told me that. And so he examined around a little bit, and then he was feeling my head. And he said, on the left side of my head, I have no pulse. So he's sending me to have an MRI. Um, but I
No,
feel like I'm kind of like, will the vascular surgeon I go to see in September be able to address this if it winds up I have a blockage in my neck
So,
also?
so absolutely, absolutely. And it all depends on what the degree of blockage in your neck is. So we don't treat a blockage that is less than 80% stenosis or narrowing of the artery. If you
Okay.
have 80% or higher, you run the risk of having a stroke. And even the mentality of treating those is changed. We maximize cholesterol, diabetes management. We, tighten the ship up to make sure that you're not getting any worse, you're not progressing, and you're not going to get complete occluded, or you're going to throw a clot into your brain and develop a stroke. Usually a surgeon that sees an 80% stenosis and it's asymptomatic based on what we have studied in the past, based on population studies, the benefits outweigh the risks. So having a carotid endarterectomy or a stent placed for an 80% asymptomatic carotid stenosis is appropriate. Now, if you're having symptoms, sudden blindness in one eye or the other eye, or slurred speech or weakness in your arms or your legs, that is associated to the distribution of where that narrowing is in your artery in your neck, then you would be deemed a symptomatic carotid artery stenosis. And even if you are 50% to 80% narrowed with symptoms, you would be an indication to do surgery on. So these days we're doing minimally invasive procedures for the carotids. We're doing stenting. We're doing TCAR, where we expose a carotid artery through a incision above the clavicle. And then we create reversal of blood flow so you don't develop stroke during the procedure, and we lay stents and then we close up the artery. It's a beautiful technique. Patients do extremely well. It's minimally invasive. The other technique is going through the groin, putting in a filter above the area that's narrowed, and then putting a stent in. About 20 to 30% of patients who have carotid artery stenosis will also have peripheral artery disease, PAD. And that's going to be translated by, when you walk, having tightness in your calves, or like a vice grip, and you have to stop and rest, and then it goes away, and then you can walk again. That's called claudication. And yes, that can be treated. But first, if you don't have rest pain, and even if you have a blockage somewhere, if you can walk 2, 3 blocks, 4 blocks, going into a strict regimen of exercise and a good diet, you can actually prolong that effect of claudication, where you can walk more than 3 or 4 blocks, 5 blocks, even up to a mile or 2 miles before your legs get really tired out. And that's the plan these days, is to conservatively manage patients with PAD before they get to critical limb ischemia. But let's say, you've maximized everything, and 2 or 3 months down the road, you still can't walk half a block, or you can't walk a whole block, or you can't walk through the mall comfortably to do your shopping. You have to stop all the time because you're having pain. That is called lifestyle limiting claudication, or lifestyle limiting short distance claudication. And if you have that, then it's justifiable to go in there and clean out those arteries and increase the blood flow. But after you increase the blood flow, you still have to continue with all the conservative measures, maximizing risk factor modification. If you smoke, you got to quit smoking. If you're around people that smoke, you have to get away from those individuals. And you need to avoid things that are going to promote inflammation in your body. And ways to decrease inflammation, there are so many different ways. My favorite way, and I'm sure Kim McNicholas's favorite way, is extra virgin olive oil. EVOO is kind of been there all the time, forever, for centuries. And now we're just starting to really understand why, people live long when they consume a lot of extra virgin olive oil. It's not the Mediterranean diet per se. It's actually just the olives and the extra virgin olive oil that mitigate that inflammatory process that our bodies succumb to because of all the stuff that we consume in this industrialized country.
And you provide a prescription for your patients to order from a place called Amphora Nueva, which has clinically proven the healthiest olive oil in the world over the past 3 years globally, which is pretty awesome.
Yep, totally, absolutely. I like how my bottles get to me. They're super fresh. The olive oil is very peppery at the end. It has great flavor and smell, and it works. I mean, My cholesterols for the past 3 years have never been this great. Not even when I was a young man in my 20s.
And
I'm way into the green in all my numbers.
And I love that you also prescribe to patients Ceylon cinnamon capsules. And you're the one that steered me onto actual research and studies that were done on Ceylon cinnamon and its effectiveness with especially A1C and secondarily cholesterol as well.
Absolutely. Yep. The best study that I saw for cholesterol decrease was about 18% decrease in total cholesterol just with cinnamon. And I think it has to do with the anti-inflammatory properties that cinnamon has on the pancreas. And it helps and it makes insulin secretion more efficient and also the absorption of glucose into the cells. The only caveat with cinnamon is that you can't take it ongoing. You have to stop, usually about a month of taking it. You need to stop for a couple of weeks because of the concentration of coumarin in the cinnamon that interferes with vitamin K anticoagulation factors, or coagulation factors, not anticoagulation factors.
I do 2 weeks since you started doing it. I do 2 weeks on, 2 weeks off, just because it's easier for me to remember. So I hope it's doing something.
Absolutely. It
We do have,
works.
the other thing I just read was chia seeds. We had a patient that came to us and said that one of her friends told her to stop consuming large quantities of ground chia seeds because chia seeds actually are contraindicated for people who are on high blood pressure medications and also on insulin. And that got me to thinking, oh my gosh, chia seeds work that well to lower your A1C and to lower blood pressure that they're even contraindicated for when you're on these medications because it can interfere with your dosage.
Yep, and it'll drop your blood pressure even further. Yeah, I mean, there's a lot of natural medicine out there that, it has been there forever and that we could tap into. But overall, I think one of the things that I'm starting to understand a little bit more is how meditation influences a lot of our illnesses. And nowadays, people are starting to do more meditation before they go to surgery, kind of calming themselves down to decrease the amount of cortisol in their bloodstream. So when they do get an intervention, they're gonna have more success than failure. So there's just so many things nowadays that we are starting to explore and understand that, I think we have a beautiful future ahead of us if we incorporate all these things.
And we have a few more folks here. I wanted to bring in Nancy really quick, just for the sake of Denise and what she was saying, because Dr. Antezana, you were the one that actually helped save Nancy and got her squared away with her carotids when other doctors were brushing her off, right, Nancy?
Yes, he did. And
Hi, Nancy.
Doctor, hi, how are you? I'm doing great.
I'm good. You look great.
I'm dancing. I line dance. I'm back to line dancing 2 hours straight the other day.
Beautiful. Congratulations.
I'm walking 10, 15, 20,000 steps a day. Not in the hurricane, but anyway, I do feel great. Yeah, he sent me to Dr. Bernard. You said you trained under him. I was a little nervous.
Correct.
You to do it. And he was fantastic. And now he feels he doesn't even need to see me anymore. Everything is clear. Hopefully I don't need him again, but yeah, saved my life.
Yeah, usually you won't. As long as you follow all the recommendations and your cholesterols are good and you're away from all that inflammation that you were in the past, you should be good. You should keep what you have.
Yeah, I just keep working on it and keep doing all these things. So, but yes, I had the TCAR surgery and it was fantastic. It was easy. I felt good within a couple of days. So, but I was a lot more, he said it was almost 100% blocked. So it was a lot worse than we thought.
Yeah, you were very fortunate that you didn't have a stroke. And that was addressed. That was great.
Yeah, and Medicare does cover that now for asymptomatic patients. At the time,
now it's changed. Correct.
Yes, that's a big deal.
Thank you, Nancy.
Totally.
Yeah, thank you, Dr. Antezana. I'll see you.
You're welcome, Nancy.
6 months.
Yep. We'll see you soon.
And I love Alan has a question. Alan, go ahead and unmute and ask Dr. Antezana your question. I believe it's about endarterectomies.
Hi, doctor.
Hi, how are you?
Good. I'm an amputee. We met last year at the Crown Point
Yes, I remember.
get together. Yeah, I'm all
I hope
walking
you
and
healed up
doing well
completely.
now.
Excellent.
Yep, and I've got a question. I had to have a endarterectomy on my profunda,
Okay.
and the doctor could not actually do the endarterectomy and ended up doing a bypass because I had so many surgeries and interventions that the nerve that actually controls the leg or the stump,
Yes.
it
Yes.
was plastered against the side of the
Yes.
profunda.
I can imagine.
Uh, is it possible? I guess this is a general question. After having an endarterectomy, can they be redone?
Can the endarterectomy be redone you're after he's done a bypass and
Well,
bypass the
no. This
artery?
is just a general question.
Okay.
Can an endarterectomy be redone?
Yes, it can be redone.
Okay.
So if you did do an endarterectomy and you develop plaque again, yeah, as long as you can get proximal and distal control of that vessel and open up that vessel again, you can clean out the plaque and repatch it.
Okay, that's the question I had. Thanks.
Fantastic.
Yeah, hopefully you won't need a redo. So
No, this is he put in a small, like 2-inch bypass, synthetic,
okay,
and it's been pretty solid for the past year. So we're
fantastic. Did
doing
he
good.
cover it with any muscle or anything?
I don't know that.
He probably did. We usually, when we were putting prostheses in there, prosthetic grafts, we'd like to cover them, with good tissue.
Okay, gotcha.
And we'll get in
And
a couple. Oh, go
I'm
ahead.
sure you've healed up. Yeah, I'm sure your stump is healed up.
Oh
Well,
yeah, very nicely.
very good. Awesome.
We'll get in just a few more questions here. Just want to make sure. I have one more for you. I'll wait till the last one, but I think we have Douglas. And if anyone else has another question, go ahead and raise your hand or just let me know. But Douglas, go ahead and ask your question of Dr. James Antezana.
Hey,
Yes,
Doug.
sir. Hey, bud. I've been
Good to
walking
see you.
Monday night doing 5Ks, but I noticed the last 3 ones that the bottom of my left foot and my toes are getting numb when I walk, and my calf goes numb.
Hmm. When was your last arterial duplex?
Don't know.
Wasn't it
You
like
got to
just
get one. You need to get an arterial duplex just to make sure everything is working well. I mean, you could have other issues, but I know you're a vascular path, and having your ultrasounds done at least every 6 months is appropriate. You should get one now just to make sure that things are okay and you don't have a stenosis anywhere.
Okay, cool.
now, do they treat for that numbness? I have so many patients that have this numbness, and doctors say, well, unless you have the claudication, we're not touching you. But I've actually seen the numbness go away when blood flow is restored, especially below the knee, because so many doctors still refuse to treat any vessels below the knee. But sometimes a little kiss of the balloon can actually bring the feeling back, from my experience in working with some doctors. And
Well,
you know,
it depends what the numbness is associated to. So if the numbness happens when you're walking and you're depriving blood flow to that area, then that individual, when the patient rests, the numbness will get better. It'll recover. But if the numbness is all the time, that might be associated to neuropathy, that might be associated to an impinged nerve or a nerve damage from a procedure, etc. So it just depends, what type of numbness the patient has. But neuropathy usually may improve a little bit, but usually does not go away completely. And it just depends on why the patient's developing the neuropathy. Is it from a keel ischemia that went bad and then they recovered some, and some of the nerve is damaged, and usually nerves won't recover, or is it just a transient issue because of ischemia due to severe claudication that subsides when the patient rests, or is it a lower back issue that the patients are suffering from, and that needs to be addressed by not a vascular surgeon but by a spine specialist.
fantastic. I'm going to just put it out there one more time. If Paula or Helen or Adrian, any of you have any questions, Marie, Jennifer, go ahead and unmute right now, or I'm going to go ahead and ask my final question of which is a loaded question, but I'm going to go ahead and ask it if you don't unmute. Just making sure. Anyone? Okay. So we have a new series. It's called Journey to Diagnosis, and it's going to be shared mainly in Peripheral Artery Disease Awareness Month, which is September. And we've noticed that a lot of doctors are very frustrated that these patients are getting to them too late. And so they really want to send the message to primary care, to patients, to podiatrists out there that we got to get these sooner through sharing experience. So Dr. Antezana, share an experience with us, the most frustrating experience of a patient who just came to you too late and you just wish they would have gotten to you sooner.
Well, I've had several of these patients come to the clinic, and there's really nothing else to do. Patients that have been stented their full length of the SFA with very, very poor results. I mean, I've stented the full length of the SFA, but before I stent the full length of the SFA, I have to make sure that there's good distal outflow. Sadly enough, the education that patients get from their primary care doctors is lacking. And it's lacking because we're in a world where primary care doctors are having to see droves of people just to sustain themselves. And when you see lots of people in an assembly line and you're going as quickly as you can, you're going to miss stuff. If you don't examine your patient thoroughly and put your hands on their feet and look at their feet, examine their toenails, you're going to miss PAD. And the PAD is going to be missed year after year until the patient finally says, hey, I can't walk even a half a block. And even though all the other parameters have been addressed, that patient's vascular examination wasn't done fully. So these diagnoses go unperceived for a long time. And when it's too late, then you get these disasters that end up perhaps at a facility, a hospital facility, and their interventionalists are just, they're putting stents left and right, and they're not really thinking out how this patient's results are going to be in the long haul. It's easy to go in there and put a stent in. It's difficult to follow a patient for many, many years to keep that light going. So you have to be, one, very cognizant of your anatomy. You have to understand the physiology and pathophysiology of vascular flow. If you're putting stents in, you have to understand that what's my outflow going to be like? Is this stent going to be beneficial for my patient? Am I going to be burning any bridges for a vascular surgeon if I cross the popliteal in a certain way, or if I'm going to jail out the profunda femoral or jail out the tibial vessels? All these things have to be a physician has to be very conscientious of what they do, because you've got one opportunity with this person, and if you screw it up, you're going to screw it up for everybody else, and then the patient's going to end up getting a bypass procedure. So I think it's very important that patients are educated well, that they are educated by their primary care doctors in relation to peripheral artery disease when the diagnosis is made. I think we are starting to make more PAD diagnoses because physicians are more aware of this condition. But education is key, and the internet, offers a wealth of information for patients. And I think, now in this time of our existence, we are having accessibility to the internet and accessibility to a lot of information, and that make us more powerful in diagnosing our own illnesses and understanding our own illnesses. It's important to continue doing what you're doing, Kim, is diffusing the word and the knowledge to the people out there so they are aware of that. Knowledge is an important tool. It gives you the power to understand and be able to take charge of your future.
I can't even tell you, can't even count how many people have actually said to me, if only my doctor wouldn't have brushed me off, I could have been in your walking program so much sooner. I actually would have walked if not, I only knew that I was at risk of, or in the early stages of, peripheral artery disease. But even more than that, how to walk effectively. There's a certain way you walk in order to grow those collaterals where you have to push through that pain. So I think that that's really, really important. I just want to, Adrian put in here, yeah, she is actually talking about her journey, 13 years long, and yeah, we helped to survive. to get the mystery in less than 2 weeks. That's amazing. So I'm so glad that you're doing so well, Adrian, right now. That's really awesome. And I'm so sorry the doctor blew you off. I hear it all the time. So thank you so much, Dr. Antezana, for doing what you do and for helping so many patients around the world, not just in North Carolina, but we even have a couple of your patients here from West Virginia that we sat down. They wanted to come here and say hello. Do you see them? Yeah, they wanted to say hello. Paula, do you want to unmute just to say a quick hello really quick, just so he can see you both before we jump off? There you are. There you are.
Daniel was the one you dealt with, and he's very well.
It's good to see you folks. I
Yes.
hope you're doing well. Hope you're doing better.
Yes. Yeah. We'll see
Definitely.
you soon. We're gonna see you soon.
Okay, excellent.
I love that. We send people, to you from everywhere, and you're always so good. We appreciate you. Go ahead and send your patient from this morning, your Rocky veteran, to us, and we'll get them on that walking program and
Absolutely, absolutely.
get them
He's only 54 years old, and he does need to be in a walking program so he can continue to open up those collaterals, so we don't have to do a bypass procedure on him.
Yep, that would be great. Thank you so much for all your time. Thank you for saving those piggies. We'll let you get back to your next cases. Thank you for taking a break and spending so much